Welcome, everyone. Thanks for joining us. This is the joint peer network meetings for Health Alliance and North Coast Clinics networks for our quality improvement leads, our CMOs, our medical and clinical leads, as well as our operations. So thanks everyone for joining together. And out of a conversation that began within the quality improvement peer network and then has come up in various settings, there's been continued interest in talking about social determinants of health, how our health centers and our networks are looking at assessing for some of the non-medical needs that our patients have, and then how we can then connect them with resources in the community to address those needs with the goal of overall, improving their health and wellness. And so we started to talk about what other health centers in the region are doing in this area, and decided that it might be a good idea to seek some information on some of the practices of health centers in the Redwood Community Health Coalition network. So we have with us today Alexander Valley Healthcare. We have Stephen and Shelley joining us. And we'll also be hearing from Petaluma Health Center. And both organizations have started down the road of integrating the PRAPARE screening tool as an assessment for some of the social non-medical needs of their patients. And we're going to hear today a little bit about what that journey has been like, an overview of how they got started, and maybe some insights into what they're doing with the information that they're able to gather through those assessment tools. So I hope you come with your questions. Feel free to put questions at any time into the chat box. And I know everyone's been putting their names in there, so appreciate that. And I think right now I'll go ahead and allow Stephen and Shelley to introduce yourselves to the group.
Hi, I'm Dr. Shelley Burdick. I'm the CMO here at Alexander Valley.
And I'm Stephen Giannelli. I'm the Chief Quality Officer here with Alexander Valley Healthcare. It's a pleasure to be with you all.
Great. Thanks so much. And just got a note that Jessica Moore with Petaluma Health Center will be joining us as well. She's having a few Zoom issues right now, so she may be calling in a minute, but I think we'll go ahead and get started in this conversation with you, Stephen and Shelley. And we were hoping maybe you could just give us a little bit of an introduction about your health center organization and, what communities you're serving, and a little bit about what kind of got you started in working with the PRAPARE tool.
Thanks. Yeah, so Alexander Valley Healthcare is located in Cloverdale, California, and our service area extends from Hopland to Healdsburg. So we have a big area of northern Sonoma County and southern Mendocino County. We serve about 4,200 patients every year. And we use eClinicalWorks as our electronic health record. We started the PRAPARE tool a couple of years ago, actually before I started. Dr. Burdick was the original provider who was willing to pilot it, and might have a little more to share about kind of why we started it then.
Yeah, I mean, it was about 3 years ago, so I don't remember the exact thing that ignited the start of it, but I think it was related to wanting to collect the information, and we were just getting our case management team up and running, so we kind of had the team and the resources to address some of the issues, and then collecting the data just for future purposes that maybe we didn't even know about at the time. We thought it would be a good idea, and maybe we could help somebody along the way.
Yeah.
Great. And so, sorry if you said this, but about how long have you been using the PRAPARE tool now?
About 2.5 years.
2.5 years. Okay. Okay, great. And I think Jessica with Petaluma Health Center has joined us. So we'll give Jessica a chance to introduce herself.
Hi, sorry about the delay on my end. I was finishing up with telehealth. My name is Jessica Moore. I'm a family nurse practitioner at Petaluma Health Center, and I'm also our Director of Innovation. Petaluma Health Center serves about 35,000 unique patients. We have 2 main sites, one in Rohnert Park, one in Petaluma, with an additional site at a homeless shelter in town, and then 2 school-based sites. And then we recently merged with Coastal Health Alliance, which is in West Marin. And so that's an additional 2 sites and about 3,000 more patients out there that we'll be taking care of. And we've been using the PRAPARE tool for about 3 years and screen our patients once a year using that tool.
Great. Well, welcome. Thanks for being with us. We appreciate it. And maybe I'll start with Stephen and Shelley and just ask you if you can share with us, what does the workflow look like for screening with the PRAPARE tool? So, you know, some questions about, do you screen all of your patients, or do you target a specific population, and who administers the tool? Just kind of walk us through what that looks like for you.
Yeah, so similar to Petaluma, we also screen now once a year. We do screen for all patients at our medical and our behavioral health site. So we do have a dental site that is separate from our other location. And because they don't have the resources to respond to a positive screen, we're not doing the PRAPARE tool over there. So it is broadly done universally at our medical location. As a part of our new patient process, a patient would get a copy of the PRAPARE form. Once someone has been a patient and they come up on their 1-year mark, the medical assistant is responsible for completing a clinical chart prep before each visit. And so they're looking during that clinical chart prep to see whether a person's due for the PRAPARE form. If they are, they make a note of that in the appointment window, and the front office staff provides a copy of the form in the patient's preferred language to the patient at check-in. The patient then completes that form and then brings it back to the exam room with them, where the medical assistant enters that data into the electronic health record and reviews the form for any positive screenings. If someone does have a positive screening, they will, depending on the positive screening, notify the provider or the case management team, ideally for a warm handoff depending on the issue. Right now with COVID and so many of our staff working remotely, it's a little more challenging. Our behavioral health and case management team are predominantly working remotely, so we've had to devise some different workflows for that. But that's our workflow under normal circumstances.
Great, thank you. And Jessica, back to you. And what does your process look like? Is it, you did mention you do it annually. So kind of, what does that look like? Who's administering the tool, and what populations is it given to?
Sure. I'll say that when we now administer it to all of our adults 18 and over, but when we started, we identified a couple of subpopulations just to figure out what process was going to work for us and see how feasible it was. So we really started screening our patients with diabetes, and then added our patients with depression because we knew that those were some populations that potentially had more risk, or that we really wanted to identify. So once we kind of piloted with those subpopulations, we found that, as a team, we really were able to do this, and we wanted to do it with all of our adult patients because we knew that there was a lot of need out there, and that patients weren't just we were relying on patients to self-report, just to volunteer, and say like, hey, I need help with food, when like really it takes a lot to do that. It's much easier if you're asked to respond. So we really felt like we wanted to get that information on all of our patients. We built it into our data analytics tool that kind of gives us all of our care gaps. So that tells us if, a patient is due for an A1C or if a patient's due for immunizations. We just built the PRAPARE tool into that. So that's the flag for us, similar to Stephen and Shelley. So when we're huddling before our shift and we identify in that care gap that somebody's due for a PRAPARE, that is a trigger. A little bit different. We actually don't have our front office staff give it out. Our medical assistants do it in the room. And we use eClinicalWorks also. And so it is in eClinicalWorks as a smart form. But when you just printed out the smart form, the formatting wasn't great. And so we built it in as a letter in our EHR, so it prints out with the patient's name, date of birth, and then we formatted it so that any positive answers are on the left and negative answers are on the right. So it's easy for anyone to sort of scan down and see, okay, this is somebody that needs help. So the medical assistants are giving that. And then we actually have them leave it for the provider to look at. And then the provider typically asks a follow-up question or two around any need to kind of identify, what kind of resource might be needed. For an example, I had a patient one time who marked, who was worried about losing his housing. And so I said, tell me about that. What's going on? I see you're concerned with losing your housing. And he said, I have a court date and I'm afraid I'm going to go back to jail. So what that patient needed was not like a navigator for housing help. It was a very different thing. So we've found it useful to just have the provider kind of check in, ask like a follow-up question or two to really identify what the right resource is. And then our medical assistant coordinates getting the resource, whether it's navigation or case management or behavioral health, that sort of thing. So that's the process that we use when we're live and in person. And we're still trying to figure out the best way to do this when we're working virtually with our patients and experimenting with, sending questionnaires electronically through our patient portal, or what does that look like? And how can we continue to collect this data that is, probably more meaningful than ever right now? There's just a lot of need. So that's where we are.
Absolutely. You mentioned the medical assistants then are the ones who sort of coordinate linking patients to resources when there is something identified through the screening. So can you talk a little bit about what that process looks like for the medical assistant? How do they help coordinate that resource?
Yeah, so we essentially put together kind of a grid of, if this is positive, this is kind of the resource that's needed. And then they're either, if it's an appointment, they're scheduling that appointment. They're also using a resource called NorCal Resources or Aunt Bertha, and that is an online resource guide essentially, and you can email, text, print information for patients about any community organizations or resources that might be relevant to them. So we kind of curated a folder of like the most commonly used resources from our navigation team so that medical assistants can also, go in and get patients connected that way. If they don't need as much kind of support around access, that they, can make the call and that sort of thing, then they can support patients in doing that.
Great, thank you. And Stephen and Shelley, what does that process look like with your sites in terms of who does that coordination of resources when something has been identified, and how do you organize that process?
So that's usually done by our case management team. They also have access to Aunt Bertha and North Cal resources and a variety of our local resources. So typically the medical assistant alerts the case manager, and then the case manager takes it over from there.
And about how many patients are your case managers working with? What does that team look like?
Well, we're a very small site, so we, in an ideal world, we would have 2 full chronic care case managers and a behavioral health case manager. We never seem to have a full case management staff, especially lately. So right now, we're working with what we've got, and they're kind of just helping us with anybody and all people. But ideally, a case manager would have, 100 patients kind of assigned to them that they're like intensely working with. But these would be more maybe side people that needed, a link to somewhere.
And did you encounter, as you were beginning to roll out the PRAPARE tool, any concerns from your clinicians or other staff about, would they be able to, or were there concerns raised about doing this type of screening, and what happens next if a need is identified? Can you talk a little bit about what that was like?
Yeah, so, again, we're so small and we're in the northern part of Sonoma County, there's just not a lot of resources. So, one of the big hurdles for starting this whole process, well, what do we do when somebody needs help? What do we even have to offer them? And sometimes we don't have anything to offer them except, support, the behavioral health team, and just knowing that we're here for them and we're listening. So just getting over that hurdle of we might not have a solution to everybody's problem, but sometimes just hearing their problem helps in some way. So just getting over the hurdle of, what resources do we really even have for everybody, and what's, a reality up here in North County. That was probably the biggest hurdle.
Yeah, and I would echo that to say that I think there's a little bit of a chicken and egg piece to this, which is that people often don't want to do the screening if there's no resource, but the other side of that is, how do you know what resources you need until you've screened? And so from a quality side, the data piece is actually really valuable to us in thinking about who we might partner with or who we might engage with. One of the challenges I think that we have with NorCal resources is that many of the resources are local to Santa Rosa or to Petaluma. And so, while it's a helpful tool for us, I don't know that it helps us maybe as much as it might some of the larger health centers in the larger areas. So we have to gather that data and work through it and think of maybe some more creative ways to connect people to services that they need.
Yeah, I think Stephen's point about kind of looking at your population and really having some data about what are the needs is really powerful when you start to approach, community partners or grants or, some way that you really could address this more, to be able to say, this percentage of our population is struggling with this, and we don't currently have anything to support that. And then capturing the data in a way that is structured so that when you do have something that addresses that, you can actually, push out that information to patients and say like, hey, here's this thing. And we know that, there was at least a time recently when we talked to you and this was brought up. So we wanted you to know about this. So there's definitely value in having the data, even if you don't have like everything that you wish you had for patients. And
as you were rolling out the PRAPARE tool, did you have clinicians or other team members express concerns in the beginning, and have those concerns been addressed? How are people feeling about it now?
Yeah, I think, it's just, sorry, it's just one more thing to do, from a clinician standpoint. So that can just get frustrating over time, more buttons to click and more forms to fill out for the patients too. They can feel that way. But once we, present it as, a tool to really help people in their social determinants of health category, I think everybody got on board eventually.
And Jessica, what about for you guys? Was that kind of a similar, it's one more thing to do kind of a thing, but as you get into it, it gets a little easier?
Yeah, I think one thing that really helped was, when we were piloting this with our patients with diabetes or our patients with depression, and we had some real kind of aha moments with clinicians and teams, like, oh my goodness, I've been seeing this patient for years and their diabetes has never been at goal. And now, like, I actually found out that, or they never come in for their appointments. And I see, like, oh, they don't actually have good transportation, or like they don't have good access to food, or they're like having tremendous stress at home. And like, I didn't really realize that or understand that before. And they never told me that, like, oh yeah, they never told you because we weren't asking in a systematic way. So I think, like, after people had a few experiences like that, it really felt much more worthwhile in a real tangible way to do this screening. So it was much easier to kind of overcome the resistance. And I think things like this, often they seem harder than they actually are when you kind of work together, and it feels like it would take forever, but it does. A lot of people don't have any needs, honestly, is the other truth. It's not that every single patient that you're going to ask this to has 10 things, right? Like, that's the fear. But when you actually start doing it, everybody doesn't need everything. And it's really about just identifying who does need it and connecting with those people. So I think that was another kind of helpful thing to see, like, what is our actual need in the population? And it wasn't as overwhelming as people feared it might be.
Right, that's a good point. And Jessica, you mentioned that that data of knowing what the needs are within your patient population can help maybe drive some new partnerships and help maybe to identify resources. Can you give maybe an idea of what kind of a partnership Petaluma has been able to establish as a result of this?
Sure. Yeah, there's two partnerships really related to food access and food security that we have developed as a result of this. One with our local food bank. So we actually started hosting the food bank on site once a week in Petaluma and once a week in Rohnert Park, and just kind of breaking down that barrier of, like, sending people to another place that they are familiar with us and they know where we are and they trust us, and then you can come get food here on Mondays from 11 to 3. And then we also partnered with Petaluma Bounty, which is a local farm, a local nonprofit farm, and they bring a farm stand to the health center on Thursdays. And they do like double bucks for EBT, and essentially are providing kind of wholesale prices for fresh local fruits and vegetables. So those are two really kind of tangible partnerships as a result of this work and kind of identifying what is the need in our population.
That's great. And Stephen and Shelley, what about for your sites? Any partnerships that have come out of seeing what the needs are within your patient population?
Yeah, I think this has actually been a bit more of a challenge for us. And in part, as we talked a little bit about the resources being centralized more so in cities. One thing that we began to explore for our diabetic population, actually in about December or so of course it's on hold, was partnering with some of the larger facilities in our area and seeing what was possible to look at doing some group visits, potentially some exercise classes or some nutrition classes. We don't really have the space in our existing facilities to do that kind of work. And so that was a partnership that we were looking to establish to try to get some, discounted rates on space so that we might be able to do some additional programming. We've also gone through some of our data to look at how the different social determinants of health impact our diabetics, and there might be some additional opportunities for partnership there, but again, some of that has been put on hold just due to timing.
Mm-hmm. Sure.
Well, the one other thing is I think it's kind of helping for interdepartment relationships right now between our substance abuse counselor and our behavioral health team. It's just kind of a way to keep them in the loop and warm handoffs available, and just the team approach to healthcare.
Yeah, I think that's a great point. I mean, we have a new behavioral health director and are working on a more integrated approach and find that this is a very helpful bridge.
Okay, great. And so, Stephen, just thinking about some of the ways that you've used this data, are you, do you have a process where you're sharing this data in some routine way with your care teams, or how are you working with the data that you're able to collect through the assessments?
So we share a data tool with many in our coalition called Relevant, and it allows us to pull each one of these, the data points. So we can look, for example, we did a breakdown of our, again, diabetic population, and we looked to see, okay, well, how many of them were struggling with food insecurity, as an example? And then was there a disparity in care based on that? So did we see a difference in A1C percentages, for example? And interestingly, the answer was no. And I actually think in part that was because we had a lot of our patients enrolled in case management, and our case manager was making sure that our patients with food insecurity issues were meeting with someone to talk about CalFresh enrollment and things of that nature. So we're starting to get a little bit more granular on that on our diabetic population. And I think we have an opportunity to, on the population as a whole. As I mentioned at the outset, Dr. Burdick started, I think, as the initial provider maybe 2.5 years ago, but I think it's only been about a year since we've had all of our providers doing the screening. And so I think we're ripe for a time for doing some larger data mining to identify some of those needs. But the diabetic data has really been telling. We've been able to see things like housing insecurity. We've been able to look at food insecurity. And one of the biggest disparities in care appeared to be race and ethnicity, but it actually turned out that that was more related to the insurance status of a patient. So there's really lots of rich information in the PRAPARE tool to be able to slice and dice. And, when we talk about breakthrough improvements, right? I mean, continuous quality improvement gets you to a certain point, and then you have to get to a breakthrough improvement. And that next step is often by identifying that subpopulation. And the social determinants of health is a really great way to find those subpopulations that need additional services.
Yeah. And Jessica, what is it looking like for you guys in terms of what kind of data you're collecting and then sort of routinely reporting out?
So we have reported out the data annually to our teams. We sort of have an annual update kind of meeting about, social determinants and using the tool. Like, there's a fair amount, there's some turnover that happens, and just kind of like resetting everyone and kind of, this is why we're doing it. This is what we're learning. This is how we're using it for, making sure that people are aware of the partnerships that we have and different things that are available. So we share that with our teams once a year at a training. And then we also are looking at that as Stephen mentioned, kind of in our internal quality improvement. We use that when we are looking at different maybe, disparities, that sort of thing. It's been really helpful to see that breakdown. And then we also, it's easy for anyone to see their data at a provider level on Relevant and kind of who's getting screened, who's not getting screened, and what the outcomes are. So we're using it in a few different ways.
Well, in terms of the who's getting screened or who's not getting screened, are there any pain points now? You're about 3 years into implementing the PRAPARE tool. Are there parts of this process that, you know, were a pain point that you have overcome, or still kind of that hurdle you're trying to get over in terms of working with the tool?
There were just a few kind of technology pieces that were difficult initially because, so we're using eClinicalWorks, and there is a smart form, as I mentioned, kind of built into that. When we came around to the second, like people were due for it again, and people were entering in those results, our numbers, like, of people screened, like, just was kind of falling down, and we, like, people were doing it and we kind of couldn't figure out why. Well, there was like a piece where they had to manually like reset the date that it was collected. Otherwise, even if they updated the information in the screen, it still had the original date of the screening. And so like there was just a little piece like that that was challenging. One thing that I didn't mention that I think is worth talking about is the PRAPARE tool kind of has a set of core measures, and then they have some supplemental or optional measures. We took this to our patient and family advisory council before we started implementation, just to hear their feedback, get their suggestions. And they looked at those supplemental questions, and they had a strong recommendation that we not include the questions about have you been incarcerated, and about refugee status. They felt like that those questions kind of triggered fear and some kind of mistrust, and kind of how, well, you know, how are you going to use this data? And they felt like the tool was much more palatable and less fear-inducing without those questions. And so we, you know, I mentioned that we kind of reformatted the tool to make it easier for us to use. That was initially a pain point too, because people were like, it's hard for me to tell, like, to easily see what the result is, and if do I need to do something or not. So that was helpful. But then we omitted those optional questions from the questionnaire that we are giving to patients. And so I would just encourage everybody, you know, every patient population is going to be somewhat different, but to engage your patients when you're thinking about implementing this. Your physical setup and, you know, your team structure is going to be a little bit different. So do just, and, you know, engage with your patients as you're thinking about implementing this, you know, obviously, as well as the staff that are going to be involved.
Mm-hmm. Right. Good advice. And Shelley, for you and your providers, any pain points as you adopted the PRAPARE tool?
You know, we've discussed just the lack of resources, but I think getting over the workflow, similarly to what Jessica's talking about, you know, ECW doesn't necessarily make it easy to use the smart forms in general. So we have similar issues with the dates and entering the data. Right now, it's just a new issue is, you know, what do we do about this now that we're doing, you know, 60% telehealth? You know, who asks the questions, and how do we ask the questions, and then how do we deal with the answers? So I think that's something we're working on right now. You know, is this part of a phone call chart prep, and the MA asks the questions over the phone, and, you know, how awkward is that for the patients? You know, one of the reasons we had it printed out and filled out was to make it feel more anonymous and less awkward to give positive answers. So that's one thing that's kind of the biggest issue right now. Like, how do we use this going forward in our new world? And we haven't really figured that out yet.
Okay.
And I would add, I mean, I think thinking about even a question like, do you feel safe at home, is a really interesting question to ask someone when they might be at home over the phone. That is a very different feel than being in the clinic, which at that point for them might feel like a very safe environment. So I think there's some sensitivity to those questions in terms of how and when you ask them that, yeah, we haven't quite figured out yet.
Absolutely. Yeah. All right. Well, I want to make sure that those joining us are able to ask their questions as well. So I would say to those of you from our peer networks who are here, you can either put questions into the chat and we'll be happy to raise those with our speakers, or you can feel free to unmute your line if you want to ask a question. So I did receive one question in the chat, which was about the telehealth issue, which you were just raising, which is how do you do this over telehealth? So it sounds like that's still kind of a work in progress and more to come on that. But if there comes a time in the future when you do have sort of a workflow, if you'd be open to sharing that, I know we have folks that are interested, so. So anyone brave enough to unmute their line and ask their questions, your burning questions?
This is Valerie from Open Door. I was interested if either site had leveraged your patient portal in sending the questionnaire in advance to patients in anticipation of their visit, and if there had been any consideration in that platform given the challenges with telehealth.
So this is Jessica. We have started to do that setup. We've done that with other questionnaires, but we haven't yet done it with the PRAPARE. We were having a little bit of difficulty setting it up with the English and Spanish. We got a little bit hung up there, and then there's been just lots of IT and informatics needs, and so it hasn't quite come to the top of the pile yet. But that is something that we are working towards and hoping to use. And right now we're just trying to get more and more of our patients on the portal so that when we're ready to use the questionnaires, that people will be there and familiar with that platform.
Yeah, I think very similarly for us, we're more focused on getting folks onto the portal rather than doing the forms at this time. I wish I had more.
Thanks, that's helpful. Jessica, remind me, which EHR are you guys on?
We're on eClinicalWorks.
Okay, thanks.
And we have a question in the chat box from Mandy asking, did you or do you see any patients burn out on the amount of screenings that they completed each visit? So has that come up as an issue?
Yeah, I mean, we're also doing the DAST and the Audit C questionnaires annually. So definitely there's some patients who just say, I just did this last time, but really it had been a year. And we let them know that they don't have to complete any form if they don't want to, and the goals of each form and why we do it. But yeah, definitely we get some negative feedback about it.
We've just tried to, because this is just once a year in our huddle, kind of identifying what are the questionnaires and screenings that the patient is due for, and which ones are kind of the priority. Maybe if they're due for a bunch, or maybe we might decide that we'll do this one today and next time we'll do the other ones. There are decisions you can make around that too.
Great, thank you.
Yeah, and just one other comment, which is I think this has got to be a pretty universal challenge. I mean, in addition to the DAST questionnaires, we screen people for tobacco. There's so many quality measures that are tied to screening, where I think as an organization we feel a certain mandate to do that. And then so something like this, which is maybe not mandated, but is vitally important to supporting patients with meeting needs that we may not be able to meet in the clinic. The importance of doing it, I think, outweighs the downsides very heavily that we might experience from patients or even providers. That's why we work hard to do it.
Right. Any other questions from our group on the line? have one question about, you both mentioned working with NorCal and Aunt Bertha for some resource referrals. Do you track those referrals? Is there any kind of a closing of the loop to see if patients are accessing those resources? Stephen, maybe we'll start with you.
Yeah, I actually just reached out to the folks at RCHC about this, since they are really the ones that hold and administer the program for us. They acknowledge that there's some issues, I guess, with the way people are using the system, and that it's become challenging for them to track which health centers and which patients are using which resources. So kind of on my to-do list is to spend a little more time with that person and try to figure out how we can do it right so that we can get a better sense of that. Because, you know, otherwise we get the really rich data about what people are potentially struggling with, but we don't get the data about, you know, what services are really benefiting people, maybe what wait times are and how long it takes to access some of those services. So we're missing, I think, half the pot, and I want to get that set up so that we can do that. The system does allow for that, and I think that's important.
So I would say I would just encourage anyone who's kind of thinking about, okay, you know, tracking, do I need to track these referrals? How do I do that? Be really like thoughtful and careful about what you kind of get yourself into. I don't know about you all, but we definitely still have some trouble tracking our medical referrals, you know, that like people do or don't go to these like very important medical appointments. And, you know, is there maybe a subpopulation where we really do need to track and make sure that people are, you know, getting the services and following through on these community-based referrals? Or is this a case where, you know, we have made it available and done everything that we can do to make it easy for patients to access, and then we're trusting them to, you know, decide if that's something that is useful to them and that they are going to follow through with? So I would just encourage you to be thoughtful about that. Good point.
We have a lot of conversations at the QI Peer Network about closing the loop on all sorts of referrals. So well taken bit of advice, yes. Anyone else on the line have a question? Do you want to unmute your line and ask your questions? We have a quiet group today. All right, well, while we're wrapping up, maybe Tricia, if you want to launch the poll for us, we have just a couple of questions to ask everyone as we start to close out today's call. You can give us a little feedback. We've been trying to develop a series of these kinds of interviews with health center leaders about what they're doing to address some of the needs of patients. And just want to say thank you so much to Stephen, Shelley, and Jessica for being with us today. We really appreciate all of the insights and sort of what you've shared about, you know, how it's been to work with the PRAPARE tool and to help connect your patients to resources that they need. So we really appreciate everything that you've shared today. Thank you so much. I'll do sort of one final call for any final burning questions. Anything else folks want to ask or add to the conversation today?
I think I just want to make one more comment, which is that there are plenty of reasons to not do this screening and to not work on the resources, but you can overcome all of them. And so if you're thinking about whether this is worth doing, there are so many needs out there that a patient has that you can help them with, even if you have limited resources and limited staff. So I would encourage you to find a way to do something. Find a subgroup, or find some way to pilot it. Find an excited provider, find an excited medical assistant. Even if you have to start small, I encourage you to do it. It's very worthwhile. It matters deeply to our patients. So don't let some of the challenges get in the way of really important and meaningful work. You can absolutely do this.
Great. What a wonderful place to leave this. Thank you. So I think we'll say thank you again to our speakers. Thanks for everyone for joining. And, you know, maybe we can check back in a few months with you guys and see if you figured out the telehealth answer to all of these screenings. And because I know that was one of the burning questions here. So thank you so much. We appreciate it.
Thank you.
Thanks for having us.
Thank you.
Thank you.